Wikipedia for this opportunity to get to speak to you today. So, do you feel a little bit dysfunctional when it comes to functional sinus surgery? Is it time to confess that you just don't know that much about FES? It's important because if you don't know what the surgeon is doing when he's operating, you won't understand what you're seeing when you're reading. Functional endoscopic sinus surgery through the nose has become the standard of care for paranasal sinus disease. But do you know what to look for in these patients? Well, it turns out the answer is, right under your nose. Join me as in this talk, I help you to become functional in your understanding of functional sinus surgery. I have no disclosures for now. I look forward to the day when I have so many sponsorships that I have many disclosures to list, but today is not that day. Paranasal sinus mucosal disease is actually incredibly common. And while it may not have the same sort of impact in terms of morbidity that other more sexy diseases that we study in neuroradiology have, like a GBM, because it is so incredibly common, it actually has a huge impact on quality of life and a huge socioeconomic impact. I like to compare paranasal sinus disease and more dramatic neurologic diseases like car accidents and nuclear power plant explosions. So is a nuclear power plant explosion much more deadly, has a much huger impact? Absolutely. But it's so incredibly rare that there is a significantly greater toll when it comes to automobile accidents than it comes to nuclear power plants. Similarly, because paranasal sinus mucosal disease is so common, its impact is quite large. Now, why do we get paranasal sinus mucosal disease? Well, it's because your nose is basically an open door to the world. It's breathing in the air and letting everything in, the good, the bad, and the very ugly. So many unsavory things can enter through your nose. So this kind of open door policy of your nose is basically the equivalent of always hitting yes on a dating app, right? Like you're letting in everyone who comes across your screen. The nose is letting in everything that's floating in the air. So if you're not being very selective on who you choose on the dating app, you're going to get some bad dates. Similarly, letting in everything through your nose is going to get you some bad actors. Most commonly, these bad actors are actually viruses. Now, I don't have to go through the history of the last couple of years to show how often we get infected with viral particles through the air that we breathe. And the problem is that when you have these viral infections in the nose, it causes inflammation of the nasal mucosa, which then subsequently block the drainage of the sinuses. And then if you don't have sinus drainage, well, then you're going to get stasis and inflammation in the sinuses as well. Now, the problem with stasis in your sinuses, not being able to clear your sinuses, are the same problems you have if you don't clear out your room. You get bacterial superinfection because you're not clearing those secretions. Similarly, if you're not clearing out your house, you're also going to get an infestation. So the problem of stasis is kind of like if your bathtub drain is clogged. If you can't drain out the water, if your sinuses can't drain, you're going to get pretty dirty water sitting in there. So you might say, well, if the problem is that the drain is clogged, why not drill a new hole to let it drain out somewhere else? So it turned out that they did try this for sinuses. This is what a Caldwell-Luck procedure was. They would drill a hole in the anterior wall of the maxillary sinus to allow drainage of the sinus instead of through the natural drainage pathways out into the premaxillary fat pad. It's essentially like drilling a hole in your bathtub when the drain is clogged. Now, while a second hole may work when you're trying to drain water, it turns out mucus is more like sheep than water. It doesn't move except where the cilia directs it, just like sheep don't move except where the shepherd directs it. So the problem is you can open any door you want, but if cilia is not pushing that mucus towards that exit, it won't go there. Just like the sheep are not going to go anywhere that the shepherd doesn't tell it. You can open all the doors you want, they'll just sit there. Similarly, the mucus will just sit there unless the cilia is directing it to the exit. And unfortunately, the cilia is not directing it towards the anterior wall of the maxillary sinus. The actual natural flow of the cilia is directed towards the natural sinus ostia. And this is where mucus will be directed and will be able to exit. Drilling another hole won't work because it's only going to exit through the natural drain. So if we can't drill another hole, we have to fix the drain we already have. And that's what FESS is. It's functional endoscopic sinus surgery. So it's helping to open the normal functional pathways, kind of like getting a plunger on your drain. And that's why it's called functional sinus surgery. That's what puts the F in FESS, because it's helping enhance the natural functional flow of the sinuses. So first we're going to talk about the actual steps of FESS, because you can't give someone directions if you don't know where they're headed. Similarly, you cannot tell the surgeon what's relevant if you don't know what he's doing. And so then we're going to talk about what you need to look for to help your surgeon for each step of FESS. So the first step of FESS is to insert the endoscope into the nasal cavity. And when you do that, the first two structures that you encounter are the inferior turbinate and the nasal septum. So the first question you have to ask yourself on every sinus CT you read is there enough room to insert the scope? Will it go in smoothly, like putting on a comfortable pair of sweats? Or is it going to be a really tight fit, like you trying to get into those jeans that you haven't worn since high school? So you basically want to tell your surgeon if there's anything that's going to make it a tight fit. And this is usually nasal septal deviation or enlarged inferior turbinates. That's what's going to make it the tight jeans that can't quite fit through. And it's important for your surgeon to know this because this may require a septoplasty or turbinate reduction before they even get started. And so they may want to consent the patient and explain to the patient that this may be required in addition to the other steps of FESS. Here's an example of a tight fit. You can see how enlarged that inferior turbinate is. It's directly abutting the septum. There is no room there. You would have a very difficult time fitting in a scope here. It's the equivalent of trying to put on super tight jeans. You're probably going to end up getting a rip there, and you don't want that to happen to your surgeon. Now, the next step is to advance the endoscope to the middle turbinate. Now, the middle turbinate is an incredibly important landmark for the surgeon. If you've actually ever seen the actual endoscopic pictures from a FESS, all you see is mucosa and mucus. It is incredibly easy for the surgeon to get lost. And therefore, the middle turbinate is kind of the go-to landmark. It's home base when they're performing a FESS. Now, the problem is because they are manipulating around the middle turbinate, you can get adhesions in this region, reactive inflammatory adhesions from kind of the surgical trauma. And therefore, when you get these adhesions, this can close up the airway that you've just worked to open. You've worked to enhance this functional drainage pathway, and then you get adhesions that just close it off again. So in order to prevent these adhesions, they medialize the middle turbinate. They basically put a suture to tie that middle turbinate medially to the nasal septum so that it won't extend laterally from adhesions and block the opening that they've just created. So I think of it kind of like they put a seatbelt on it to keep it in place. Eventually, scar will take the place of the suture and it will be a permanent medialization. So what are some of the important anatomic variants you need to look for in the region of the middle turbinate? Well, the first is a paradoxical turbinate. So I think the normal middle turbinate looks kind of like a boxing glove. And that boxing glove, well, it's punching the nasal septum. So always in the normal anatomy, you should see a boxing glove punching the nasal septum. In a paradoxical turbinate, that boxing glove is actually turned the opposite way. So instead of punching the nasal septum, it's punching the lateral nasal cavity wall. So for paradoxical turbinates, you look for that boxing glove hitting the lateral wall rather than the nasal septum. The next important variant you should look for is conchobulosa, which is basically pneumatization of the middle turbinate. Now, the middle turbinate fills with air in the same way you fill a balloon with air when you're making one of those fun animal shapes. So when you first start blowing it up, only the proximal portion of the balloon starts to expand. Similarly, you can get pneumatization of only the vertical lamella of the middle turbinate, only that proximal portion of the balloon, the proximal portion of the middle turbinate. Then, as you continue to blow up that balloon and fill it with air, eventually the whole balloon fills. Similarly, eventually you not only have pneumatization of the vertical lamella, you have pneumatization of the entire middle turbinate. Finally, after you fill the balloon with air, you start to tie it off to make your little animal balloon. Similarly, you can get a tie-off in the middle turbinate, where you tie off that upper pneumatization, and all that you're left with is the lower pneumatization of the conchal portion of the middle turbinate. The next step is an uncinectomy. This step is used to open the drainage pathway of the maxillary sinus. It's kind of like popping the cork off of champagne to open it up. You're popping the top off of the maxillary sinus drainage pathway. Now, to understand how an uncinectomy works, you have to understand how the maxillary sinus drains. To understand the maxillary sinus drainage, think of the mucus like travelers. Mucus is trying to leave the maxillary sinus the same way travelers are trying to leave their home to go on vacation. Now, the maxillary sinus cavity is called the antrum, and you can kind of think of the antrum like the airport. It's where all the people congregate, waiting to move out, to leave to their final destination. So this is where all the mucus sits before it has to go up to leave. So this is kind of the airport of the maxillary sinus drainage. So when you leave the airport, the first thing you do to be able to leave is you walk up to the gate. So the first door to exit the maxillary antrum is the natural sinus ostium. It's like the airport gate to enter the plane. It lets you out of the airport, but you're not actually on the plane yet. Similarly, the maxillary sinus natural ostium lets you out of the antrum, but you're not free yet. Just like how an airport gate leads you out of the airport into a long hallway, that hallway being the jetway, the ostium opens up into its own hallway. This hallway-like structure is called the infundibulum. So, just like how you must walk down a jetway to get to the plane, you must go through the hallway of the infundibulum before you can truly leave. Now, the end of the infundibulum is called the hiatus semilunaris. And this is kind of like how the jetway ends in the door of a plane. The infundibulum ends in the hiatus semilunaris. So this is the exit that finally allows you to leave the maxillary sinus drainage pathway, just like how entering the jet door finally allows you to be able to take off. The hiatus semilunaris opens into the middle meatus. Now, the middle meatus is a space in the nasal cavity that's actually a common meeting point for many different sinus drainage pathways. So think of the middle meatus kind of like a jet plane, right? Many people from different places come together on one jet plane and then leave together for their final destination. Similarly, sinus drainage pathways from different areas in the paranasal sinuses all come together into the middle meatus where they can then drain into the nasal cavity together. So here's your summary of the maxillary sinus drainage. You start at the airport, which is the maxillary sinus antrum. Then you go through the gate of the natural sinus ostium before you traverse down the jetway of the infundibulum to go through the jet door of the hiatus semilunaris that lets you get together with all of your fellow travelers from all the different sinuses in the jet that is the middle meatus. So what does the uncinate process have to do with all of this? The uncinate process is the wall that helps to create this drainage pathway. It is what forms the infundibulum. So it must be taken off to expose that infundibulum and natural sinus maxillary ostium. So it opens up that natural sinus drainage from the maxillary sinus antrum. So when you take down the uncinate process, that exposes that natural sinus maxillary ostium and takes down one hurdle that the mucus has to go through. It no longer has to pass through the infundibulum. It just has to exit through the natural sinus ostium. Now remember, this natural sinus ostium is the natural endpoint for the mucociliary flow in the maxillary sinus. So mucus is going to be propelled towards this ostium by the cilia. So if the ostium is opened up, then more mucus can get through. So how much do we want to open it up? So the minimum that you can open it is by just doing an uncinectomy. You just take down the uncinate process, you just expose it. So this is kind of like pretty light lifting. This is kind of like just like a handheld dumbbell. Now, this can be further enlarged front to back with a type 1 sinusotomy, where you enlarge the natural sinus ostium 1 centimeter posteriorly. And this is some more hefty lifting. Now, if you really want to be benching, then you do a type 2 sinusotomy, where you enlarge the natural ostium by 2 centimeters both posteriorly and inferiorly. And finally, if you're really getting into Olympic weightlifting, that's a type 3 sinusotomy, where you basically take the wall down all the way to the level of the inferior turbinate. So what does the surgeon need to know before he opens up the sinus ostium? Well, one of the important variants is an accessory ostium. So normally the mucociliary flow is propelled towards the natural sinus ostium. But if there is an accessory ostium in the wall of the maxillary sinus, this causes abnormal airflow. Air comes in not just through the natural ostium, but through the accessory ostium. And this abnormal airflow disrupts the normal mucociliary flow. It's kind of how like a strong wind ruins a first date, right? If the wind blows, it kind of messes everything up and causes chaos. Nothing's going to work right. You can't recover from that. Similarly, that air through that accessory ostium will cause disruption of the mucociliary flow the same way the strong wind disrupted your dinner. Therefore, the surgeon has to take the wall down all the way to include that accessory ostium. So that's included in the new post-operative ostium, so that there's not this wind coming through the back door to ruin the normal mucociliary flow. The next variant that the surgeon needs to know about is whether or not the uncinate process is atelectatic. And by that we mean it's directly opposed against the orbital wall. And this is important because it increases the chance that when the surgeon takes it down, he'll accidentally violate the orbit. The uncinate process is kind of like this thin covering, like a carpet covering something very dangerous that you can't see because the carpet is covering it. And when it's pulled away, whoa, you're at a cliff. So similarly, he doesn't want to pull away the uncinate process and find that, whoa, he's at the cliff of the orbit. So you need to let him know about that. Next is an ethmoidectomy. The anterior ethmoid air cells are cleared all the way superiorly to the skull base. So it is important when looking at the ethmoid air cells to tell the surgeon if anything's going to be in the line of fire as he moves superiorly towards the skull base. One of the most important variants is if the anterior ethmoidal artery projects into the ethmoid air cells. So the anterior ethmoidal artery runs in the medial aspect of the orbits. And if it projects into the ethmoid air cells and is hit by the surgeon during surgery, this can be a devastating event. Because remember, he's working through an endoscope, and trying to fix a bleeding artery through an endoscope is like trying to fix a leaking hose with tongs. It's incredibly difficult. So you need to let the surgeon know if the anterior ethmoidal artery is in the line of fire as they clear the ethmoid air cells all the way to the skull base. So when do you want to say that the anterior ethmoidal arteries are truly projecting into the ethmoid air cells and at risk for injury? You want to call it when it looks like a diving board. If it looks like a platform that you think you could dive off of, then it's at risk of being injured. Another important variant to mention is the depth of the olfactory fossa. The deeper the olfactory fossa, the greater the risk of skull base perforation as your surgeon extends superiorly all the way to the skull base in the ethmoidectomy. And for this, we use the Quiros grading system, where grade 1 is a very shallow olfactory fossa, 1 to 3 millimeters. Grade 2 is a moderately deep olfactory fossa, 4 to 7 millimeters. And grade 3 is a very deep olfactory fossa from 8 to 16 millimeters. So why is the depth of the olfactory fossa so important? If you think about it, the sinuses are full of danger, especially when there's a surgeon with an endoscope in them. And the Quiros tells how far these olfactory recesses dip into this danger. So grade 1, you're just kind of, dipping your toes in, and chances are you won't get bitten. Grade 2, well, you stuck your leg all the way in, and so the risk of running into danger is a bit more. In grade 3, well, frankly, you're swimming with the sharks at this point, and you're at high risk of getting injured. And in FES, the danger is the surgeon. As the surgeon goes superiorly, clearing the ethmoid airway cells all the way to the skull base, if that olfactory recess is sitting far down in his field, there's more chance that he could injure it and perforate the skull base. So here's an example of when this happens. You can see here that there's this focal region of encephalomalacia in this patient who has undergone a FES because the surgeon perforated the skull base and caused brain injury to the region of the gyrus rectus. And it does look like a little shark bite. So the dangling leg got bitten this time. So how do you remember what the measurements are for the Quiros grading system? Well, the way I remember it is that there are 3 grades that go in increments of 3 millimeters. So 1 is 1 to 3, next 3 is 4 to 7, and then above that, well, it's basically anything above 7 is going to be a grade 3. So hopefully now you have more than a perfunctory knowledge of functional surgery. So the steps of FES are first to enter the nasal cavity. It is important to mention anything that may make it difficult for the surgeon to insert the scope. So enlarged inferior turbinates or prominent nasal septal deviation. Next, the medialization of the middle turbinate is performed. Any sort of anatomic variants of the middle turbinate, such as concha bullosa or a paradoxical turbinate, should be mentioned. Next, the uncinate process is taken down to open that maxillary sinus. So it is important to mention if the uncinate process is atelectatic, because that could possibly increase the risk of orbital perforation. You should also mention any sort of accessory ostium, because then they have to adjust the depth and the extent of the uncinectomy so that it will include that accessory ostium. Finally, the ethmoidectomy. So you want to mention anything that may be in the surgeon's way, as that shot goes straight up to the skull base. So things that may be in the way, the anterior ethmoidal artery and the olfactory recesses. Any sort of variations of that may put them in the line of fire, you need to mention. So remember, when it comes to reading studies for functional sinus surgery, remember, form follows function. The anatomy guides the surgery. So hopefully now that you understand the anatomy and the surgery, you will have a lot to profess when it comes to studies for FES.